Wake up. It's the Sleep Unplugged podcast, episode 160. Still sleepy after CPAP. I'm not dead. I'm not myself. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm a neurologist, sleep specialist, and your host for this episode of the podcast. If you're new to the Sleep Unplugged podcast family, welcome. If you're a veteran, welcome back. We're glad you're here. If you want to get in touch with the podcast, you can. Social media, Dr. Chris Winter. Instagram, Dr. Chris Winter. Twitter, X. Bluesky, Threads, all Dr. Chris Winter. We have a YouTube page where we post video content of all of our episodes, as well as the Spotify music playlists, plural. We're on volume 4, where we post the music we talk about at the top of every episode, and this episode will be no different. Excited about this episode of the podcast and sort of moving on our exploration of sleep apnea. We've talked a lot about sleep apnea, starting with episode 5 of the podcast, a discussion of sort of milder sleep apnea and what that means. We've talked about various treatments for sleep apnea, oral appliances, surgery, CPAP. And now we're going to the next level, which is you've got mild sleep apnea, you've got severe sleep apnea, you've treated it through some process, a surgery, a CPAP, whatever, and things are still not where you want them to be. Why did you seek treatment for the sleep apnea? For most people, it's because they're excessively sleepy. It might be because the spouse is concerned or their own sleep is bothered by snoring and breathing disturbances. But then the next phase becomes, okay, you're on the CPAP. What do you expect? And what do you do if it's not reaching that expectation? So we'll explore that in today's podcast. Comments, corrections, criticisms. Got a great one. We did an episode on extreme insomnia recently, and Sarah wrote the podcast, and I just want to read her letter because I think it's not only wonderful she took the time to do it, I also think it's really important to hear what she has to say. We welcome perspectives here, and she is an individual who practices within this realm. So I'm always looking for color, expanding on ideas, and for all of you professionals out there who work in the field of sleep, criticism and corrections. If you listen to something and you disagree with it, please, 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 please feel open to write the podcast and say, Chris, I think you got this wrong, or you're missing the boat on something. We learn a lot when there is intelligent disagreement. So I really, really welcome that from you guys. Sarah wrote, just want to drop you a note to say thank you for your podcast, and in particular, this week's episode about extreme insomnia. I wrote to you about a year ago when I was newer to CBTI to thank you for how much your work has helped me on this venture. Now, a year later, I continue to find your work very grounding as I practice CBTI. It's been the most rewarding stage of my career, and I'm grateful for you and others who are experts in the field. What stood out to me as I listened this week is the way that insomnia takes a stronghold, not only because of an entrenched fear of not sleeping, but also because being an insomniac or a bad sleeper can become an identity. I've noticed that people I work with can resolve their insomnia much more quickly if they are open to adjusting that identity. It doesn't really matter how long they've had symptoms or how severe those symptoms are. What seems to matter is how strongly that identity has taken root. I think if you can see yourself as a person who sometimes has trouble sleeping, whatever that means, rather than an insomniac or a terrible sleeper, you position yourself to be much more open to take the risk to try something new. CBTI can be hard work. You can't just listen in on the session and go about business as usual for the rest of the week. It requires willingness to try what seems counterintuitive and sometimes to feel worse before you feel better. And it requires imagining that you are a person who can feel better and be something other than an insomniac. That kind of work sometimes takes longer than the 4 to 6 or 6 to 8 sessions CBTI is often said to, quote, work, in quote, over. I think that as a CBTI practitioner, it's important that I share that if CBTI doesn't, quote, work, in quote, as quickly for someone, it's not because they are broken or the CBTI isn't effective. Sometimes it just takes longer to unpack all the pieces that get in the way of making changes. I wonder if the frequency advertised short duration of CBTI can do a disservice to both practitioners and clients alike. Other people see improvements quickly, sometimes people don't. If, as providers and clients, we can be okay with slowing things down and making subtler incremental progress, I genuinely believe the most extreme insomniacs can see a change for the better. Anyway, I wanted to share a bit as I found your discussion particularly relevant to conversations I'm having with clients all the time. Thank you again for all you do in the sleep community. Well, thank you, Sarah. And if you're hearing a funny sound in the microphone, you may not be, but if you are, my older dog Alaska is having a dream apparently at my feet. Sarah brings up a lot of things that I mean, we could have gone on that extreme insomnia episode. The identity is important, how you're tied to it. And one of the points I was trying to make with that extreme insomnia episode was when you've invested in it, it takes a lot for an individual to say, oh, wow, all the providers, all the things I tried, all the money I spent, all the anguish, all the stories I'm telling my friends and family, it wasn't that I couldn't sleep. It was just something different than that. And that's part of that identity, isn't it? That's part of the identity. And it's tough. Again, I've never read the article that said I struggled for years and years and years with extreme insomnia. I had no idea insomnia was nothing like I thought it was. And then the article unfolds from there. That realization and admitting something led me astray. I don't blame the patient. I kind of blame the provider to some extent. So, Sarah, I really appreciate that. I'm glad you liked that. And if you're new to the podcast, every first episode of the month, we always talk about insomnia. So there will certainly be more to come. Before we get into the meat and potatoes of the podcast, we're going to talk a little bit about the song lyric in this episode. I'm not dead. I'm not myself. That is from the Stone Temple Pilots song Tripping on a Hole in a Paper Heart from their third album, Tiny Music Songs from the Vatican Gift Shop, 1996. This was a incredibly difficult album for Stone Temple Pilots, particularly Scott Weiland, to make because he was really in the throes of drug addiction at this point. In fact, one of the reasons why they recorded the album in a home out in Santa Ynez, California, was yes, they wanted to reproduce kind of what Elton John did, recording Goodbye Yellow Brick Road in a home, but they really wanted to be isolated from other temptations in the rest of the world while they recorded this episode. And you can tell it's recorded in a home, particularly on the song Adhesive. It just kind of sounds like it was recorded in a room and not necessarily a studio. And this album represented a big shift for STP away from the grunge and more into a glam rock sort of vibe. And somebody asked me recently in my social media, favorite musical group, favorite artist, and I thought to myself, I thought I've been pretty clear here. Favorite artist, David Bowie. Favorite musical group is Roxy Music. So I'm very partial to sort of a glam rock aesthetic. And it's probably the reason why this is my favorite SDP album, even though their fourth album, which I think was like album number four or something like that, sort of continued that to some extent. Really hear the struggles of Scott Weiland on this song, which sounds uplifting and kind of positive, but if you really listen to the lyrics, it is a tour de force of lyrics that really sort of dive into his existential doubts and addictions and things of that nature. So really dig this album. Huge fan of Big Bang Baby as well too. It's another great single off that album. So we're gonna put Tripping on a Hole in a Paper Heart, people in a Paper Heart on the volume 4 of the Spotify music playlist. And I really think the lyrics are germane to this episode. I'm not dead, I'm not myself, as we sort of get into the meat and potatoes of this episode. an individual comes to a provider, they are diagnosed with really, really bad sleep apnea. And suddenly the clouds part, the angels sing, and you're not dead anymore. This suffocation that's happening 78 times an hour, oxygen saturations down into the 70s is over. And starting the first night you put that CPAP on or wear the oral appliance or have, recover from the surgery, you're not having that extreme breathing disturbance that's happening over and over. It's gone. New lease on life. You are no longer racing towards death because of your sleep apnea and all the risk factors that come about from that. I was just contacted by, it was either Prevention or Women's Health Magazine this week about tell me why sleep apnea relates to cardiovascular disease. And it's endless. I mean, there's so many ways between direct links between cardiovascular disease and sleep apnea, but also sleep apnea increases your chances of being overweight. It makes you more sedentary. It changes blood sugar, da 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 da. I mean, all of these things kind of link themselves to cardiovascular bad outcomes. So those things are gone or at least resolved. You were a smoker, you have stopped smoking. This is a great step towards prolonging death. We don't get to avoid it, but we can statistically prolong it. But the second part of the Stone Temple Pilot lyric is I'm not myself. And this is tough because lots of people who've had sleep apnea for so long, they don't remember what it's like to not have it, to not be excessively sleepy. So when you start the CPAP, the individual starts wearing the CPAP, they're going to feel better in most cases. I've got a few people in my clinic with really bad apnea. So we're not talking about episode 5 mild sleep apnea. We're talking about significant sleep apnea. When I see significant sleep apnea, 30 or more breathing problems per hour, the number of people who are going to treat that apnea and not feel at least somewhat better is very small. It can happen, but we're going to ignore those three people who had terrible apnea, got the CPAP, and it didn't really change anything. So when we think about sleep apnea, it's a massive burden. We're talking about 1 billion people in the world who have it. We are working really hard to find the people who do have it and treat them. And I think in the United States, we do a pretty good job of doing that. We can do better. There's plenty of people out there with sleep apnea who continue to have it. And the, cardinal manifestation, a cardinal symptom of sleep apnea is excessive daytime sleepiness. And generally speaking, we think about excessive daytime sleepiness, sort of being academically defined as a person who has this persistent difficulty maintaining wakefulness and alertness during the waking periods of their day, not when you're watching TV at 11 o'clock at night, but at work, at your job, taking care of your family, driving a car, you're struggling to stay awake. And for a lot of individuals, they have tremendous problem. A lot of individuals with sleep apnea have tremendous difficulty with excessive daytime sleepiness. So how do we quantify that? We've talked about the Epworth Sleepiness Scale, um, having a score greater than or equal to 10. How likely are you to fall asleep reading a book, watching television, a passenger in a car for an hour, driver of a car parked at a stoplight after you eat lunch, sitting quietly in a meeting, lying down to rest when you have circumstances allow you to, etc. So 8 situations, how likely are you to fall asleep? You get a score of 0 to 24, 10 or above is higher. We sometimes do MSLTs. They're typically reserved for evaluating hypersomnia down the line. So somebody comes in and says, I snore, I stop breathing, my wife is concerned about things. We're probably not going to do an MSLT. We do the sleep study. They have sleep apnea for the sake of this conversation, pretty significant sleep apnea. We treat their sleep apnea and they come back. Chris, this is the best thing in the world. I feel great. Okay, let's repeat that MSLT. I'm sorry, let's repeat that Epworth Sleepiness Scale. You had scored a 13 when you first came to see me. Now you're scoring a 4. You're feeling good. Partner's feeling good. No real evidence of excessive sleepiness. Fantastic. That's about 50% of people who treat their apnea. And I would qualify that as 50% of people who treat their apnea at about the 3-month mark. Can a CPAP immediately change somebody's excessive sleepiness? Absolutely. Can it take others a bit more time? Sure. 3 months is the number that I give. Once a person's been on CPAP therapy, sleep apnea therapy of some sort for 3 months, they should probably have seen the improvement that they're going to see. So again, the prevalence is somewhere between 40 to 60% of people with sleep apnea continue to report severe excessive daytime sleepiness when they're diagnosed. And about 50% of those people, once they're treated, continue to have it. That's a big number. Um, uh, you know, it can be lower. Some evidence, there's some studies that say 34%, 22%. I keep 50% in my head. I think that but depending on how we define excessive sleepiness, is it a certain number in an Epworth? Is it a concern about ongoing fatigue, sleepiness, tiredness, low energy? Just, 20 to 50% is what I would say. It also depends upon how much they're using their CPAP. I would say for people who are very consistent CPAP users, you're probably looking at closer to more like 33% of individuals are going to still have excessive daytime sleepiness. If you're looking at all sleep apnea post-diagnostic treatment, people who are using CPAP, not using CPAP oral appliances, consistent, not consistent, I think can get up to closer to 50. So we're dealing with not an inconsequential population of people that are still having a lot of sleepiness despite the fact that they were diagnosed with sleep apnea and treated for their sleep apnea. And I think that's the focus of what I really wanted to talk about, that a lot of these individuals are still having excessive sleepiness, perhaps 1 in 5, that's 20%. So the message I want to get out to listeners, to the family and friends of listeners, if you've been diagnosed with sleep apnea and you're treating it, outstanding. I'm really excited about that. And I hope that that treatment makes a huge difference in terms of how you feel. But we have to be very careful that we are really looking for that in individuals. And I'm not sure every sleep provider is doing that. Meaning that I do think that for a lot of providers, you came, I heard, diagnosed you with sleep apnea. Here's your CPAP, and that's it. I'm going to see you once a year so I can redo your CPAP mask and supplies. Every 5 years, we'll get you a new CPAP. But there's honestly this sort of an automatic assumption that, oh, you're on CPAP, so you're good now. Not necessarily. And that can be a weird combination interaction to be dealing with. The provider that's not really questioning for that excessive sleepiness, and the CPAP user who, number one, probably feels a lot better than they did prior to their CPAP. And I'm going to say CPAP, yes, oral appliance, yes, surgery. We're just going to say CPAP because that's the most common treatment. So, number one, they feel better. And as we've talked about with hypersomnia as it relates to narcolepsy and IH, better is not normal. So they feel better. And number two, there might be a little bit of a reluctance or a strange countertransference of, well, I don't feel comfortable talking to Chris about the fact that he's done all this stuff for me, gotten a CPAP, believed in my, whatever, and I'm better. But am I being kind of whiny or needy saying I want to be even better than this? So I think that as providers, I was just talking about this week, we've got to create space for patients to complain about us, to want more from us, so we have to kind of create that. And we do that, in my opinion, by assuming nothing's working rather than assuming things are working perfectly with the CPAP. Oh, you got your CPAP. How are you doing? Oh, I'm much better. Oh my gosh, thank you so much. Well, great. I'm so glad to hear that. I'm glad you're doing well. So I'm going to set you up for an appointment in a year. Whoa, 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 whoa. We're not done yet. I'm glad you're doing well. Tell me more about it. Did you repeat the Epworth sleepiness scale? Let me tell you something. I've had a lot of patients over the years tell me how amazing the CPAP is, how much better they feel. Da, 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 da. And you do it. You're like, well, this is kind of worthless, but I'm going to repeat the Epworth, but I know they're doing so much better than the 13 they scored before. No, they're not. You repeat the Epworth and they score 13. And it's a fascinating question to ask a patient. When I asked you these questions before I diagnosed you with sleep apnea, you scored a 13. And I'm so glad everything's going well with you right now. But you still scored a 13. Why do you think that is? It's not common, but these kinds of things happen. And we have to be on the lookout for it. And who are we looking for? Who are the people that might have a little bit more difficulty with excessive sleepiness in terms of that patient population that we see? Well, it's going to be people with more severe sleep apnea. So when that person comes in having nearly 100 breathing problems per hour, my radar is already up that yes, this CPAP is going to change their life. That can be misleading. It can be distracting. They're going to come back and say they're much better. Is the CPAP therapy totally normalizing the individual who had 88, 97 breathing problems per hour? We have to assume that in those individuals with bad sleep studies, bad hypoxemia, I mean their pulse ox went really low, those people might be at more at risk for having continued excessive daytime sleepiness despite great compliance with the CPAP. People who are obese tend to fall into that category more. Older individuals and males, people with unusual upper airway anatomy, big tonsils, constricted airway. Look out for people who are smokers, people who use alcohol, other medications. Sleep problems are common in patients with sleep apnea. So a lot of times they're using medications to help them sleep because they didn't know the sleep apnea was their sleep problem, not some sort of insomnia, not some sort of use of pills. Again, this might be a provider providing these things. So we want to be able to look out for these types of things. Comorbid asthma, allergies, hypothyroidism, these kinds of things we want to look out for because they may be little clues that the people that we treat for sleep apnea with CPAP may still be having a little bit more difficulty with that symptom of excessive sleepiness. I'm not myself. I'm not dead. Don't have my sleep apnea anymore, but I am not myself. So again, residual excessive sleepiness is most common during the initial phase of CPAP therapy, first 3 months. 40% of patients who reported sleepiness at the start of therapy tend to resolve it. After 3 months, the prevalence of excessive daytime sleepiness significantly drops to between around 10 to 20% in those hardcore CPAP users, 1 in 5. So, what are we doing for those 1 in 5 people? We're talking about it. Hey, I feel like you seem like there's still a fair amount of sleepiness now that we're 6 months out of starting the CPAP. What do you think? Again, giving them that space to say, well, I don't think so. I think I'm really a lot better. Okay, well, your Epworth is still high. Your partner still complains that you fall asleep during activities during the day. Again, we're in some ways as providers redefining or maybe defining what is normal. I fall asleep. Well, I fall asleep watching the news every night at 6 p.m. Okay, is that normal? I don't think it is if somebody's sleep amount, sleep quality, which we've radically improved with the CPAP, and sleep consistency is normal. Maybe it is, maybe it isn't. So I start with driving because I'm not tolerating continued sleepiness while driving an automobile in my patients who are on CPAP. Great that you're wearing CPAP. Why are we still falling asleep driving? Why are we still nodding off? Why is our car still telling us to take a break? So I think it's very important for patients to understand there are FDA approved therapies for excessive daytime sleepiness related to sleep apnea. And we've talked about these medications before in relationship to narcolepsy and IH and shift work disorder. This is modafinil, armodafinil, and solriamfetol. So that's Provigil, Nuvigil, Sunosi. So I'm not going to get into these drugs that's sort of beyond the scope of this podcast. But what I do want to say is that if you're somebody still struggling with excessive sleepiness, even after you've treated your sleep apnea, there are therapies out there that are perfectly appropriate for you and quite effective. The data of these medications is really strong. These are medications that tend not to have a lot of side effects. They're usually very well tolerated by patients. They can be used, a bit more as needed or every day. And I think it's important for us to have these conversations with our providers because more and more sleep apnea diagnosing and therapy is falling outside the realm of the sleep provider and into the realm of the primary care doctor, which I think is great. I have no problem with that. I think run-of-the-mill sleep apnea probably should be there. Now, there's some exceptions. One is I'm worried about that primary care doctor or the non-sleep physician ending with the CPAP. Okay, well, I thought about sleep apnea, diagnosed it, put them on a CPAP, they're better, I'm moving on. I think there's some follow-up there that needs to happen. So if you're a primary care doctor who often does their own home treatment or home diagnostics of sleep apnea and you order the CPAPs, you do it all yourself. This is an important follow-up over that next year. Is the sleepiness going away? And how are you going to measure that? What are you going to use the Epworth? Are you using similar scales? Do you have your own way of assessing this? It needs to be assessed. And then, are you familiar with the therapies if excessive sleepiness in the treatment of sleep apnea still exists? I think that's extremely important. So, if you're a patient and you're like, hey, CPAP's great, but I could be better, I'm not myself, you need to advocate for yourself because these medications can not only change lives, but they can save lives. Have I ever had somebody who's treated their sleep apnea and worn a CPAP fall asleep in the car? You bet. You bet I have. So my job is to do everything in my power to alleviate that excessive sleepiness if it still exists. So these are questions we have to ask our patients. And just because somebody's wearing a CPAP, has a sleep doctor, does not mean that the symptoms are not there. And it doesn't mean you shouldn't ask. You see somebody who comes into your OB clinic, psychiatric clinic, whatever clinic, and you see, oh, diagnosed with sleep apnea back in 2017, and they're wearing a CPAP and they're very compliant with it. It's still in bounds and important to ask about sleepiness in those people because they're hiding. So that's it. That's what I wanted to talk about in this episode is that sleep apnea therapies radically reduce excessive sleepiness, but not in everyone. And if you're one of those people who's still sleepy, despite the fact that you don't miss a day on your CPAP, talk to your sleep provider about therapies for hypersomnia despite the fact your treatment of sleep apnea is going swimmingly. We often call it refractory sleepiness in sleep apnea. That is a thing. It might affect you, and there are therapies for it. Dr. Chris Winter Instagram, Dr. Chris Winter Twitter, Dr. Chris Winter Bluesky, Dr. Chris Winter Threads. I have two books: The Sleep Solution, Why Your Sleep's Broken and How to Fix It, as well as The Rested Child, Why Your Tired, Wired, or Irritable Child May Have a Sleep Disorder and How to Help. Thank you very much to Sarah for the communication. Thank you for listening to the podcast. Check out our Spotify music playlists if you're a Spotify member. And until next week, sleep well.